Approach to chest pain. From symptom to diagnosis, learn to think like a Canadian clinician. Why chest pain matters. Chest pain is one of the most common and most dangerous presentations in clinical medicine. A missed or misdiagnosed case of chest pain isn't just an error, it can be fatal. This is where clinical vigilance truly becomes a matter of life and death. MCCQE1 expects broad, safe, and evidence based reasoning. We will use PQRST, red flags, and pattern recognition. Step 1, rule out the killers. Always assume danger first. Think worst case, then work backward. Big six life threatening diagnoses: myocardial infarction, pulmonary embolism, aortic dissection, tension, pneumothorax, cardiac tamponade, esophageal rupture, pearl. If you miss these on MCCQE1, you may fail the case. Let's break down the PQRST framework for characterizing chest pain, a high yield clinical tool in both the MCCQE1 and real world medicine. P. Provocation and palliation. What brings the pain on and what makes it better? If it worsens with exertion, think myocardial infarction. If it worsens when lying flat, consider GERD. If it improves when sitting up and leaning forward, that's classic for pericarditis. Q. Quality of pain. How would the patient describe the pain? Crushing or pressure like pain suggests myocardial infarction. Sharp or stabbing may point toward pulmonary embolism. Tearing or ripping pain radiating to the back is concerning for aortic dissection. A burning sensation? Think GERD or herpes zoster, or radiation. Where does the pain travel? To the left arm or jaw is typical of cardiac ischemia. To the back often indicates aortic dissection. A dermatomal pattern of pain is classic for herpes zoster. S. Severity. How bad is the pain on a scale of 0 to 10? A 10 out of 10 intensity should raise alarms. It's a red flag for serious pathology. T. Timing and duration. When did it start and how long does it last? Sudden onset pain? Think pulmonary embolism or dissection. Gradual onset is more typical for myocardial infarction. Intermittent brief episodes suggest stable angina or esophageal spasm. Now that you've mastered the structure, let's bring it to life. It's time to apply the PQRST framework to real world scenarios. Because understanding symptoms is one thing, but interpreting them in context is where clinical skill begins. Case 1, Mr. Joseph, 64-year-old male, arrives with 30 minutes of crushing central chest pressure radiating to the left arm. He's diaphoretic, nauseous, and appears pale. Vitals: BP 90 over 60, HR 110, O2 sat 94% room air. ECG shows ST elevation in 2, 3, and AVF. SOAP note: S. Subjective. 64-year-old male with acute retrosternal pressure radiating to left arm associated with diaphoresis, nausea, and shortness of breath. Onset at rest, no relieving factors. O. Objective. BP 90 over 60 millimeters of mercury, heart rate 110 beats per minute, respiratory rate 22, oxygen saturation 94% room air. Cardiac exam normal S1 and S2 heart sounds, no murmur. ECG, ST elevation in leads 2, 3, a VF, troponin T pending. A. Assessment. STEMI, inferior MI, likely due to right coronary artery occlusion with hemodynamic compromise. P. Plan. Mona, morphine, oxygen if sat less than 90%, nitroglycerin cautiously, aspirin 160 to 325 milligrams chewable. Notify interventional cardiology for emergent PCI, dual antiplatelet therapy, ticagrelor or clopidogrel. Serial troponins plus repeat ECG. Admit to CCU. This scenario demonstrates how to prioritize emergent coronary syndrome with classic ECG changes. If you see hypotension plus inferior STEMI, consider right ventricular infarct, avoid nitrates. Case 2, Ms. Mandy, 35, presents with sudden pleuritic chest pain and dyspnea 4 days post-cesarean section. She reports mild hemoptysis. Vitals: heart rate 118, respiratory rate 26, O2 saturation 90% on room air. SOAP note: S. Subjective. 35-year-old woman with acute right sided pleuritic chest pain, dyspnea, and mild hemoptysis. No fever or prior cardiopulmonary history. Post op day 4 from C section. O. Objective. BP 116/78 millimeters of mercury, heart rate 118, respiratory rate 26, oxygen 90% room air. Lungs clear, cardiac normal, no calf swelling. Wells score 6, high probability. A. Assessment, high risk pulmonary embolism in post operative patient. P. Plan, stat CT pulmonary angiogram. Baseline creatinine, troponin, ECG to exclude RV strain. Initiate therapeutic anticoagulation, low molecular weight heparin or IV unfractionated heparin. Oxygen supplementation, admit under internal medicine, monitor for signs of hemodynamic instability. In the exam, a young woman with surgery, dyspnea, and pleuritic pain, always think PE. Remember, Wells score greater than 4, go straight to imaging plus anticoagulation, not D-dimer. Case 3, Mr. Chen, 48, reports a 6-month history of retrosternal burning, worse after spicy meals and when lying flat. No exertional component, pain improves with antacids. Soap note. S. Subjective, 48-year-old male with episodic burning chest discomfort, triggered by food and supine posture. No radiation, dyspnea, or nausea. Long-standing heartburn history. O. Objective, vitals normal. BMI 31, normal cardiac, GI, and pulmonary exam. A. Assessment, gastroesophageal reflux disease, GERD, classic presentation, no red flags. P. Plan, lifestyle changes, weight loss, dietary adjustment, head of bed elevation. PPI trial, omeprazole, 20 milligrams daily for 4 to 8 weeks. Counsel on smoking cessation, coffee, and NSAID avoidance. If symptoms persist or red flags arise, refer for upper endoscopy. GERD is common, but on MCCQE1, you must exclude cardiac and esophageal emergencies first. GERD improves with PPIs, MI doesn't. Case 4, Ms. Amara, 29, presents with left-sided chest pain reproducible on palpation, no shortness of breath, normal ECG and vitals, recently started CrossFit. Soap note. S. Subjective. 29-year-old woman with sharp, localized chest wall pain, worse on movement and palpation, no red flag symptoms, recent history of increased physical activity. O. Objective, vitals normal, pain reproducible at left fourth costosternal junction, cardiopulmonary exam unremarkable, A. Assessment, musculoskeletal chest pain, costochondritis. P. Plan, reassure and educate, NSAIDs as needed for pain, modify activity temporarily, follow up if symptoms persist beyond 2 weeks. MCCQE1 loves this diagnosis, but only after ruling out serious causes. Always correlate with a normal ECG, vital signs, and non radiating pain. Recap and exam strategies. Let's wrap up with key principles for MCCQE1. Always think anatomically: cardiac, vascular, pulmonary, GI, MSK, neuropsych. Use PQRST plus red flags to triage quickly. Apply SOAP documentation to demonstrate clinical reasoning. Know Canadian guidelines, when to use ECG, troponins, CT angio, and when to consult. In multiple choice, pick the diagnosis you must not miss, even if others are plausible. Outro. This was your advanced exam-oriented approach to chest pain, brought to you by Become a Better Doctor. Rewatch this, practice your SOAP notes, and stay focused on safety, structure, and sound clinical reasoning. See you in the next high-yield sessions.